you mentioned adjuvant therapy here, and adjuvant immunotherapy in particular, because I think that's a great segue into one of our next topics, and of course some of the most compelling data in urothelial cancer actually presented at this meeting, ASCO GU 2024, and that's the AMBASSADOR study. So I think maybe we can go over that.
Sure.
Guru?
So the AMBASSADOR trial is a phase 3 trial comparing adjuvant pembrolizumab versus observation. It was not placebo-controlled, with co-primary endpoints of disease-free survival and overall survival. This is exactly the same as the CheckMate 274 population, so high-risk muscle-invasive disease with or without neoadjuvant chemo. If it had neoadjuvant chemo, it could be PAT T2 or higher. If you did not have neoadjuvant chemo, you had to be T3 or higher. And so in this study, so slightly different co-primary endpoints, survival and DFS, unlike the CheckMate 274, which was PD-L1 high and intention to treat. So this has been being reported today as we speak at the GU ASCO Symposium. The abstract is out, showing that the one of the co-primary endpoints, disease-free survival, was met. The median DFS went from around 14 months to 29 months. So I would say it's in the same ballpark as the CheckMate 274 data. So that's nice to see. So we need to wait and see what the rest of the endpoints look like, and they're still waiting for the full presentation.
Yeah, which I think we're all awaiting eagerly in actually just an hour or so.
I think it's interesting, to Guru's point, you see at least a replication of the positive signal, the positive finding of CheckMate 274 in a trial that uses an anti-PD-1 versus observation. Because before that trial, we had a tie, right? We had the Atezo versus observation. It was a negative trial. And then, as you said, in Vigor 010, and then we had CheckMate 274, that was a positive anti-PD-1 versus placebo. And there was some discussion about the performance of the control arm that was really different, right? The performance, the median DFS of the placebo of the CheckMate 274 was only about 11 months, while the performance of the median DFS in the observation of the Atezo trial was higher, 16.6 months. So this, some people thought may have to do with the potential difference in the results. Right now, I think that it's a tiebreaker, the AMBASSADOR trial.
Yeah, I really agree. It does support the use of adjuvant immune therapy to prevent relapses. We don't have overall survival from any study in the adjuvant setting. And so it does raise the question of, are we just treating the patients who have immunosensitive disease earlier? Could we just treat them at relapse? I personally think it makes sense to give adjuvant therapy, because when we wait for the relapse, what we sometimes see is rapid progression, brain metastases, pulmonary emboli. It's a lot of morbidity, maybe mortality, by waiting for relapse. And so treating in the adjuvant setting makes a lot of sense. Now, I guess I'd pose it to the group. If you have a patient in front of you on Monday and you have the option of giving them adjuvant nivolumab or adjuvant pembrolizumab, do you choose? How do you choose? Do you flip a coin? The data, the DFS in the AMBASSADOR study is 29 months. The DFS in the CheckMate 274 was only 22 months. But is that a deciding point, or is there more to it there?
Well, yeah, I would say these cross-trial comparisons are always tricky, especially when the numbers look similar and when the hazard ratios are essentially identical, right? So I don't know that these numbers themselves will help us come to the decision of to resolve this question between Pembro and Nivo, but I don't know what everyone else.
I agree with you, and I want to hear Karine and Guru as well, but I agree with you. It's very difficult to compare across trials. To your point, Vadim, the hazard ratio is very similar in all comers, intent to treat population. I think Pembro and Nivo has the same mechanism of action pretty much. So I don't think we have enough differentiating factors between the two. As of today, Nivo has an FDA approval. We have to see what will happen with Pembro. It's very possible to have that too. And I think it will be nice to see actually the manuscript as well, to tease out some more details, patient population characteristics, and some differences in the endpoint, how you define disease-free survival. These might be some nuances to look at, but for now, I think the data look pretty comparable in terms of hazard ratio.
Absolutely. And I think one other question that will come up is for patients that do progress on adjuvant immunotherapy, then what is the landscape going to look for those patients? So,
yeah.
Would you give EVP to a patient who progresses on
I think
immunotherapy?
I honestly think that I probably would at this point, but of course it's not based on any.
Well, And it depends when that progression
Right,
happens
right.
too,
How
right?
soon is it happening?
I agree with you. I think I would give EVP in patients who progress on adjuvant therapy, just because I think there is something special going on between EV and the pembrolizumab
Like
in
a
terms
synergy.
of synergism. So I don't want to deny the patient the chance for synergism. Although the textbook answer is you would do just the EV.
Yeah. Well, so let me ask you to elaborate actually. So if you have someone, let's say, who is on the adjuvant regimen, on adjuvant pembrolizumab, let's say, and they're progressing actively on that regimen, do you just add EV, or do you and continue the pembro, or do you
Exactly.
do you stop?
In that case, I would continue the pembro and add
You
the
would.
EV rather than stop the pembro.
Okay, so you would not retreat, I guess, but
Read through.
start EV pembro
Yeah.
no matter what.
You know,
Yeah.
there's preclinical evidence
Yeah.
that there's immunogenic cell death with MMAE containing antibody drug conjugates. So you
Yeah.
essentially lyse the cell with this, and you draw and release a number of immunologic mediators, sort of signals. You draw in immune cells, and that was the whole rationale for combining immune therapy with EV. I don't
Yeah.
think we've proven that that's what happens, right? If you look at 302 and compare it to what we know from 301, you know, the overall response rate in 301 is in the mid-40s. The overall response rate in 302 is in 70s, about 70%. So it's about a 25% delta.
Yeah.
So is that just 1 + 1 is 2? You know, if you're giving the immune therapy, because the response to immune therapy is about 20%, or is it 1 + 1 is 3? Are we really getting some magic that happens there? And as you say, I don't think we know, and so I think it's very reasonable. You know, these patients, if they're not getting cured with immune therapy, EV by itself, chemo by itself, sacituzumab, none of those are curative, and so I think it makes sense until we have better data, better guidance to really try and continue this and generate that long-term durable immune response.
Which makes the point of the phase 3 trial, the ecocacrin A0231, a very relevant one because we don't know the answer, right? And that will hopefully be answered in that trial with Sachi Pembro versus Sachi to see the immunotherapy challenge question. Personally, until we have more data, my arbitrary approach is something in between with what you said. If someone is progressing while on checkpoint inhibitor, I'm not continuing it. It'll be different than what you said. I just pick between 3 and 6 months, let's say treatment-free interval. And if the patient is progressing beyond that time frame of treatment, I may use Pembro EV. If it's progression while on the IO, I may just do EV alone.
EV alone.
Yeah. If they have already neoadjuvant chemo before. Again, arbitrary, but I don't think that's the right answer.
Yeah, I think I'm actually in general in agreement with that. I think, as you said, we don't know the exact time interval that would make a difference there, but I think probably some time interval does make a difference, and potentially in the future we'll have more data to help guide us in that situation.
It's a great question, and I think there's no right answer here.